Parkinson's is the fastest growing, second most common neurodegenerative condition in the world. So what can we do? Well, our partners today, the Auen Foundation, are at the forefront of cutting-edge research and policy aimed at ending Parkinson's in our lifetimes. In the meantime, lean on human support organizations like PRO to help you through it. You are not alone. You are not alone. So let's get into it. I'd like to welcome our first panel to the stage. We've got Dr. Legge, Dr. Shields, and Ethan Henderson of Michael J. Fox Foundation. Come on up. I'll get out of the way. And I just want to welcome Ethan to the stage, who will be facilitating this panel with a brief bio. Our first panel for today is Parkinson's Today, Treatments and Standards of Care. Ethan will be facilitating today's panel. Ethan received his diagnosis of young onset Parkinson's disease in 2016. However, his deep involvement goes back to 2001 when his father was diagnosed with Parkinson's. And I know there's some Notre Dame folks in the room today, so his father was actually a professor at St. Mary's, I believe. Go Irish. Ethan became an ambassador to help educate the public, bring more resources to the community, and provide care for his father. And he has participated in multiple clinical trials to further research for better treatments of Parkinson's. Welcome, Ethan. I will hand you the floor.
Thank you. Thank you. Well, thanks everyone for coming out. As Eileen said, it's a gorgeous desert day, and it's a joy and a wonderful surprise to see so many people. I will introduce the two panelists, and then we'll dive headfirst in. So, first, immediately to my left is Dr. John Legge, a board-certified neurologist with fellowship training in movement disorders. Dr. Legge emphasizes communication with his patients. And I quote him, "I listen to my patients tell their story. From that, I find out what is important to them, which provides me with the understanding on how best to guide their treatment plan." Dr. Legge is located in Palm Springs at the Eisenhower Health Center at South Palm Canyon. Welcome. We are also joined by Dr. Jessica Shields. Dr. Shields is a fellowship-trained neurosurgeon who earned her MD, PhD at LSU in New Orleans, focusing on non-invasive brain stimulation. She completed a research fellowship at the National Institutes of Health and specializes in deep brain stimulation, cervical spine surgery, cranial surgery, and spine trauma. Dr. Shields prioritizes a collaborative, patient-centered approach to care. Outside of work, she enjoys family time, hiking, swimming, and cooking. Welcome, Dr. Shields. So let's cut to the chase and jump headfirst in. Dr. Legge, what is Parkinson's disease?
So, first, I'd like to say thank you for the invitation and the ability to participate in this event. It's really an awesome community to practice in. I want to give a special thanks to the Parkinson Resource Organization, you, Ethan, with Auen Foundation, Dr. Shields, thank you for coming. And then, of course, all the patients and caregiver, family, loved ones here. It's a delight to be a part, so thank you. Parkinson's is a complex disorder. It is, our current understanding is that it's related to the loss of dopamine-producing brain cells. So it's a slowly, gradually progressive brain disorder, generally characterized by classic movement symptoms. We oftentimes see tremor, but it's characterized by a slowness disorder that can have those movement symptoms, but oftentimes non-movement symptoms. It can affect smell and sleep, bowel movements, et cetera. Everybody's Parkinson is different, and that owes to the unique biology. The chemistry changes that go on in the brain in every patient is very different. But we look for hallmark symptoms that are tied back to that dopamine loss, and that defines the Parkinson that James Parkinson described back in 1817 in his classic essay, the essay on the shaking palsy, for which it's named. We don't have a cure for Parkinson yet, but we have very effective treatments to manage symptoms.
I'm glad you said yet. There are lots of exciting things that are on the horizon, near and in the far. We'll hear more about that later today, but I think there are some exciting things that are happening right now. You mentioned dopamine. I remember reading somewhere that upon diagnosis, a good percentage of dopamine has already been lost in people with Parkinson's. Can you, is that true, or how did that happen?
Yes. So the current understanding is that there is an area in the brain called in the brainstem, which is the stalk that connects the brain to the spinal cord, called the substantia nigra, the black substance, that is black because it produces the dopamine. Those brain cells are black, and we see that black substance gets washed out to white as those brain cells are lost. We estimate at least 70% of the dopamine-producing brain cells must be lost before symptoms show up. So there's a great deal of redundancy, but by the time the Parkinson's symptoms show up, we do estimate that there's at least a significant portion of the dopamine cells are lost. Hence, that's another avenue, perhaps, for treatment and intervention.
Yeah, it sounds like it. The brain is such an intricate system, and it's amazing what can be done now, and then what. Dr. Shields, we'll get to a deep brain stimulation and other areas of that area in a little bit here. It's amazing what has happened. I'll just go off on a quick sidebar. As my father was diagnosed back in 2001, the amount of work that had been done from his diagnosis to my diagnosis was good. But since 2015 to today, it's absolutely amazing what has happened in research in symptomatic treatment and other types of Parkinson's treatment. What I'm most excited about, and we'll hear again more, is what's happening between now and, say, 2, 3, 5 years. It's going to absolutely just, I think, blow everyone out of the water what's happening, and it's an exciting time to be involved with this right now. Dr. Shields, we were talking about brain, and Dr. Legge mentioned the dopamine loss. In your work with deep brain stimulation and others, how does that, when is it right for someone to think about that as a possible treatment or a possible step in their journey?
First and foremost, when Dr. Legge decides so. But when he says it's time is when it's time. But I think the ideal patient who's a good candidate for DBS is they're starting to take their dopamine-acting medications 4 times a day. Their off periods are becoming more troublesome and unpredictable. Their dyskinesias are becoming troublesome. And that's a time when it may be time to consider DBS as a way to reduce the medication requirement and kind of even out those on and off periods.
That's good. We'll dive more into that in a little bit, but I think I like your answer when Dr. Legge says it's time. I know here in Coachella Valley that Dr. Legge is an important fixture here, and we're hoping that more and more can come, and we'll talk about that also at some point. About what we can do to help bring the attention to this area for treatment. I want to backtrack here a little bit and ask, when someone is given the diagnosis of Parkinson's, what do you tell them? How do you explain it to them? And what is, we all know Parkinson's is not a death sentence. It is a life sentence. So can you tell me how you go about telling people and what they should expect?
Yes. Now, I like to quote Michael J. Fox for that. He says, "You don't die from Parkinson, you die with it." And that's very true. It's when I say things change gradually because of the dopamine change. And so I do like to set the stage of say, here's what I think's going on based on the history that was presented to me and what we see on the examination. Oftentimes, we may order complementary tests, MRI scan or something called a DAT scan, DAT scan, to confirm a diagnosis, or to help support a diagnosis, I should say. And that test picks up dopamine changes on the brain, so to speak, that can help clarify if we're dealing with a Parkinson diagnosis or something else, potentially. I do like to explain basically that if we're dealing with Parkinson and we're in a particular stage, first and foremost, I like to speak about what it is and then what we do about it. Before treatment, there may be trials. So very importantly, as many of you may have heard me talk to you, we don't want to go on treatment before we've made a decision about potential clinical trial, as those treatments may invalidate one's candidacy. That is, if you go on the medicine, you may not be able to be on the trial because they want you fresh. They don't want you having taken anything. So we have that discussion. This is individualized, person to person. That already starts to be very much tailored discussion. Some people can travel, some people can't. We're not having a lot of trials here in the desert, so we're talking about LA, Vegas, San Diego. That may exclude people. Age may exclude people. Other comorbidities, other disorders or diseases may exclude people. So we have to lay the groundwork, move step by step, educate. I don't expect answers at that day. I give a lot of resources from our partners here in the area, the Parkinson Resource Organization, Parkinson Foundation, Michael J. Fox. I give a lot of education. I think that is key, because if you know what I'm talking about, we have a shared understanding, then the next steps in the plan will make more sense. And that may be going for trial, that may be not starting treatment yet, but hearing me preach about exercise, or that may be starting on treatment and still hearing me preach about exercise. So treatment being dopamine medicine, traditionally.
That's really good to hear, and you hit the exercise nail, and I want to spend some time on that. When I was diagnosed, the first thing he said was, keep exercising. I was an exercise enthusiast, and I did that, but do what you can to keep moving. If you don't move, you're going to, what they call the shrinking disease, because your body does. And the exercise, can you speak more on exercise and how it helps those of us with Parkinson's?
It's a complex question, and we're still understanding all of the neurophysiology behind the exercise, but we know for all manner of brain disorder, be it Lou Gehrig's ALS, multiple sclerosis, Parkinson, Alzheimer, when you move it or lose it. Reinforcing healthy brain signal, flowing down, stimulating the muscle and getting it to contract, and doing repeat activities and bicycle or swimming or boxing or whatever. This is potentially disease slowing, reducing the rate of dopamine loss, and in many patients makes the medicine work better and last longer. And so that's a very important aspect and it makes you feel better, let alone all of the metabolic, cancer, stroke, heart attack, everything else. It's therapeutic for the Parkinson.
That's wonderful. So exercise is absolutely vital to help slow the progression, but also stave off other types of diseases that may affect us, which will end up affecting our journey. You mentioned trials, and that's an extraordinarily important thing for not only just today, but for future generations. I participate in trials because I want to help children and grandchildren, my nieces and nephews, for future generations. There is I will tout on the Michael J. Fox Foundation website. It's called Fox Trial Finder. It is a great way you can type in your information, click a few boxes saying what you're interested in, and it will produce a healthy list of different trials that people can participate. I will say, not just people with Parkinson's, but for control groups, for those of you who are our care team people here. As well, we have some other things that can be found on the website, so that's good. We don't want to go specific into medications, but can you talk about some of the typical medications that might be possible options for people newly diagnosed or further along in their journey?
The gold standard, so the baseline treatment that has been studied since Dr. Kotsitz and Hornikowitz just, started experimenting with this medicine back in the 50s in Vienna, is levodopa, dopamine. If the condition is the brain's not making enough dopamine, and I will frequently talk about dopamine in terms of gasoline. Let's pretend dopamine's a chemical gasoline, right? And so if the brain's not making gasoline over time, dopamine's not being made over time, the engine can seize up, frequently cause tremor and stiffness. So we give back gasoline in the form of the dopamine. That varies how much and how frequent their engine needs to be treated, so to speak. So the gold standard treatment is a medication called carbidopa-levodopa, of which there are many different derivatives that have come about from that medication. However, we have other, what I call adjuvant therapies or add-on therapies that may even be started before levodopa, which those medicines talk to the brain, so to speak, and tell the brain to hold on to its own dopamine longer. And so it extends the effect that your own brain's making the dopamine, thereby enhancing its effect and can offset some of the symptoms before we have to add some externally from the outside. We use what your brain's already making. Those are called MAOB inhibitors, rasagiline, selegiline, sulfonamide are some of the names. But gradually over time, as the Parkinson changes, we expect to gradually go up on the amount of dopamine to play catch up. If we don't supplement the engine gasoline, it's continually going down. If we keep the medicine the same, you'll be running at an ever-increasing deficit of symptoms. And so so we have to go, and if we start having a lot, as Dr. Shields said, a lot of dosing requirement, side effect, or inadequate off time, we're talking about, or an on time, where if you're off most of the day, that is, the medicine's not working, that's when we start thinking about advanced therapies like deep brain stimulation, ultrasound, or some other device therapies.
And that brings me to Dr. Shields. With deep brain stimulation, we have wonderful representatives from Abbott, Medtronic, and Boston Scientific. 3 different deep brain stimulation or companies that we get to choose from or participate in the choosing of that. Can you talk about what deep brain stimulation does, what its benefits can be, and what the hope is for someone that's thinking about going down that journey?
Yeah, I think of DBS as kind of like a pacemaker for your Parkinson's disease. Dr. Legge and I work collaboratively to choose the best target for your specific Parkinson's disease and what we think would help your Parkinson's disease best with DBS. We implant the device, and the beauty of DBS as opposed to focus ultrasound is that it gives you and Dr. Legge the opportunity to play with the settings and adjust to changes that you're having with your disease state or side effects that you're having from stimulation or medication. Focus ultrasound is great. I'm probably launching into a future question.
Please, no, keep going. Yeah, no, that's great.
Focus ultrasound is a great modality if you're, I think Dr. Legge and I were talking at dinner recently. He's like, I don't want any wires in my body. I don't want any devices. And so if you're of that mindset, I think focus ultrasound is a great opportunity because it's an incisionless surgery. It doesn't require any implant of any device, but what you get is what you get. And so a lot of patients will get focus ultrasound and then DBS in the future. I think, you'll see all the companies. I think you, as a patient, educate yourself on each of the companies that provide DBS surgery. And the big thing is you have to be comfortable with your rep support, because they are the ones who are going to help you manage your device. And so you really have to be confident in the rep that you're getting. And, of course, your surgeon and, of course, your treating movement disorder neurologist, but the reps are really going to guide you through your stimulation process and troubleshooting your device and things of that nature. So you just have to be confident in the individuals that you're working with. I think all the companies are great. It's an arms race. They're all, this one gets this and the other ones get this. And so it's, they're all kind of equal. And if you want one to have a rechargeable battery, just wait a year, they'll get it. Because it's the nature of medical device issues. But yeah, I think it's a decision. If you're interested in surgical treatments, it's a decision to make carefully. Talk to all the reps, talk to people who have gotten either surgery about why and why not, pros and cons, and then of course talk to your treating physicians about what's the benefit of all the therapies.
Great. I'll again just tout on our website. We've got I think it's about a 72-page booklet on DBS, talking about the pros and cons, interviewing people who have had success and people who have not. We need to be honest about that, but it's a fantastic resource, and I know people are curious about that, so thank you for sharing so much about that. And I think having three more companies into the system makes it a better choice for us. Competition is always healthy in that field. Dr. Legge, you mentioned the gold standard carbidopa-levodopa back in the 60s. This is 2025. Can you tell me a little bit about why nothing has been as effective as this, and what's your hope for the next few years or the future of research?
Dopamine remains the best medication for Parkinson's movement motor symptoms. It does not treat constipation or smell or thinking or blood pressure. However, trying to devise a medicine, a shot, a pill, a vaccine of some sort to slow or stop the progression has been vexing. And however, as we indicated some earlier, this is an exciting time. With the rollout of the alpha-synuclein seed amplification assay from the Fox Foundation discovery from PPMI, we're getting new biomarkers, new treatment modalities. As we were talking earlier offline, I joke and say it may be a 16 or 17-year-old with AI, looking at this, but when you start integrating some of the new biology, advanced brain imaging, new pathologic methods, and understanding the individual biology of the Parkinson, that's when we can start cracking open doors. And that really has taken from the 1990s to now, so that has been challenging, but we're getting more precision-based medicine, and that's when dopamine is going to start to be no longer the standard of care, I hope one day. And we're seeing those changes in the trial thinking, how we're gearing about working towards new treatment pathways. That's advancing, and we're looking a little bit at the Alzheimer literature as well to help guide us. So things are exciting and changing.
That's wonderful to hear. In addition to the medication and exercise, I know you are up on the literature of assistive technologies, wearable technology, things like that monitor us, can give data, provide data back to you or other companies that can help with our care. Can you talk a little bit about that, please?
Yes, so a lot of the focus now on devices are helping both the patients and the doctor understand how symptoms change throughout the day. That's a lot of the current focus. For instance, wearable devices, I wear an Apple Watch. There's other devices, there's apps on the phone that serve not only to monitor how is and Dr. Shields, you and I worked together recently on an app called the Parky app, P-A-R-K-Y, FDA approved, to help monitor when your medicine kicks in and tracking your symptoms throughout the day, creating a beautiful chart of tremor versus dyskinesia on or off time, helping us understand quantitatively and qualitatively, more qualitative, how are the medicines working? When should I maybe make an adjustment? Let alone the reminders it gives the patient. They're moving beyond that. There are wearable devices, gait aids, laser props, maybe in the glasses, maybe even in the shoes, that produce a laser for one to step over if there's gait or walking problem, freezing or stutter steps that develop. Not to sound like a broken record, but again, there's new AI-driven technology being integrated into the devices. Some of these devices, for instance, some of the deep brain stimulation. New imaging technology, merging the imaging with some of the deep brain stimulation to improve programming and speed and effectiveness of the deep brain stimulation. Worked very well recently, and it's neat stuff. And so this is some of the technology we're looking at.
It's so worldly. It's like Buck Rogers. As a child, I remember that. Part of someone's journey with Parkinson's is sometimes the feeling of loneliness, of being removed. Can you, either of you, talk about ways to how to build a care team that can help you through, that time, or other types of people that we should include on our team to help us with our journey? I can let you guys just riff on that.
I've been, I moved here three years ago, and I've been so impressed with some of the local community for movement disorder patients. I thought, this is a very small community. It's the desert. I don't know what our patients have, but I think our patients feel very connected. And I think, just a part of going through this process is getting connected to other people who are also going through the process. So we have the, what is it, the singing?
Songshine.
Songshine.
Yes, Rock Steady Box.
I love that group.
Yep.
This group, I just think, reaching out for other patient support is amazing. Of course, your physician care team is a good resource, but I think, just looking to your own local community is amazing. And it's a really, really invaluable resource that we have in our community, which is super important.
I agree. I think, the reason having a care team is important is because it improves quality of life. And as we kind of said from the beginning, this is about getting people connected. The center, I draw all the time during my clinic appointments, but I would draw this. The center is the patient, and outside of that's the caregiver, family, loved one, and then everything else is the outer. So that's me. That's a wonderful neurosurgeon. That's your primary care doctor. That's your pharmacist. That's your community support group. That's Parkinson Resource, the national organizations like Fox. That's your faith groups. That's your exercise classes. Those things together keep you connected, and that's what's important.
Yeah, and I think that's really important, is pulling in from different areas throughout the community, and Pro has all the connections and all the information about the local resources, which is invaluable. What are you most excited about with Parkinson's research?
I truly think we're looking more in the basic biology. We're understanding more and more about the basic biology, the inflammatory pathways, and this is opening up new treatments. Not only, we're scouring the databases of what is already out there and could be approved. We're looking at, you may have heard of ACE inhibitors. These are blood pressure medicines, certain cancer medications. These medicines are already FDA approved, already have a safety track record. We know how to dose them, but could they be used now off-label for Parkinson? That's happening. Vaccine therapies for Parkinson, gene therapy called GDNF, glial-derived neurotrophic growth factor, trying intracerebral infusion of dopamine, where they're putting a catheter into the ventricles, the brain spaces, and infusing the dopamine right into the brain. Stem cells. There's a lot of neat things going on. And as I indicated before, we are gleaning some information from the Alzheimer literature. Not that these are the same disorder, but the pathways of inflammation could potentially be linked.
Been reading a lot of literature on that recently.
And so, and with the new funding bill coming, these are things to be excited about because we're going to get a lot more attention.
Yeah, that funding bill, I think, is going to be addressing our third panel, which is really, really important. Dr. Shields, what are you most excited about?
I have a surgical bias, so all these studies that are interested in intracerebral infusion of dopamine, gene therapy, I think, I think that's kind of the way going forward. I think some of these like oral injectable medications are kind of spraying dopamine all throughout the body, and I think it needs to be more targeted, and that's why some of the surgical and lesional therapies work so well with Parkinson's disease, is because the dopamine works in specific areas of the brain, and so I think we have to get to that place and find something that works, and I think gene therapy is really promising.
Exciting to hear. Thank you. Can you touch just briefly on alternative medicine options that might help meditation, deep breathing, et cetera? Are there things that you suggest, or obviously it's an individual choice or individual where people get different benefits, but are there other areas in that alternative way?
So I think I am a big believer in CAM, complementary and alternative medicine. I am. That's what you call, when you look it up, that's what it's called. Acupuncture, chiropractic, meditation, obviously all of the therapies from physical, speech, occupational therapy. The benefits are clear. They help. How long they help can be debatable. Certain modalities or certain treatments may not be covered by insurance, and that can be limiting. Admittedly, that can be limiting.
Yes.
But absolutely, we partnering with acupuncturists, therapists, and chiropractors. Supplements, I'm very evidence-driven in my own practice, and so I gave a lecture last April about the use of supplements in the Parkinson changes. And so I'm a believer in that, but I always say, please talk to your doctor, because supplements can have untoward effect on swelling and bleeding and other things, and we want to make sure interaction with other medicines, and these are over-the-counter, don't require a prescription, so we want to be safe, right, but thoughtful. And so do your research. I talk to you about the research. We talk about it together and then chart a path forward, but these things can be very helpful for, again, the name of the game is quality of life. So if it helps, that's something to entertain.
I know I benefit from meditation, deep breathing, and I was mentioning to a couple here that I even a quick cat nap, 10, 15 minutes, and I incorporate that with my deep breathing. Along those lines, there's a question from the audience is diet and Parkinson's. Are there certain foods we should be eating to help, certain foods we should avoid? Can you both talk about?
Yeah, I'll give my 2 cents quickly. But the best diet we think that's having more and more evidence is a more mind-style diet, or a more plant-based diet with more limited animal products, but Mediterranean influenced. The MIND diet is a Mediterranean intervention for neurodegenerative disorders, and it's very good for heart disease and brain disease. It focuses on whole foods, fruits and veggies, lean meats, if you're going to eat meats like chicken and fish, sparing red meat, probably no alcohol, The alcohol is a toxin. The best amount of alcohol is none. We're seeing that. I balance all of the things I say about diet is that, as far as I know, you only live once. And diet can be a great pleasure. Food. So, I think it does not need to be these don't need to be punitive diets, but a Mediterranean, what we call MIND, mind type diet is very helpful. And could potentially, again, there's evidence there that it could be anti-inflammatory and potentially disease slowing. And so, I'm a chocoholic, so you got to enjoy things, but we want a plant-based, more focus on that, limited animal product, lean meat type of diet.
That's really helpful. Anything to add to the?
I am not as well versed on the subject, but I think like in terms of overall brain health, I believe in fatty fish. So I think salmon and those types of diets are helpful for the brain overall. I don't know, like if there's any specific evidence on Parkinson's, but
Yeah, no, I like the acronym MIND. That's really helpful to remember. The chocoholic reminds me, I lost my smell early on, and taste is bad. So highly processed sugars, I'm just addicted to them. But I try to eat the MIND diet. I try, but that just is the one thing I taste. And I know it's a dangerous route, but it sounds like MIND diet is also helpful for everyone, regardless of a diagnosis or not. Dr. Shields, we've got a couple questions here around DBS. Really great question. Why does DBS work?
So DBS works by targeting those specific areas in the brain that are known to have basically like electrical deficiencies from being a part of the dopamine circuit. So if you have a tremor predominant Parkinson's disease, we put the lead in the area of the brain called the subthalamic nucleus. And that helps, one, connect to the dopamine pathway, but two, it's known to be a tremor center. And so basically it's like a pacemaker, so it sends electrical signals to overcome the disordered pacemaker that's happening to tell your hand to tremor, and it shuts that off. And it basically just scrambles up the signals to have it send out more normal signals. Another target that's used is the globus pallidus. And it acts in a very similar way. It's just not good for patients who are tremor predominant, but it basically acts to kind of stimulate the cells to act more like dopamine is working. So I think of it as a pacemaker for the brain.
If you have DBS, and this is a follow-up question, if you have it and it's not successful, what are options after that?
So I think, there's several kind of troubleshooting things that myself and Dr. Legge go through at that time. One, make sure it's in the appropriate place and it doesn't need to be moved. Two, you can try a different target or try a different modality, like focused ultrasound. You would have to have your DBS removed. And then, the beauty of the current situation with all the companies is there's a lot of options with directionality of stimulation, changing the pulse widths, and basically there's so many options that we can try before we kind of give up on the DBS therapy. I think overwhelmingly, majority of patients say, I wish I had done this sooner. I think it's pretty rare, like I would say, 10% of patients have ineffective DBS, but I think 90%, they're like, why didn't I do this? I wish I had done this. And I understand it's scary to go through surgery, and it's scary, to have somebody operating on your brain, but I think it's all about quality of life. And so if you can delay your disease progression 5 to 7 years, I think it's a good option.
Roll back to the basics here. What type of exercise should I be doing and how often?
So that's a great question, and it's under research. The VA had a large study through their PADREC, the Parkinson Disease Center of Excellence, that the Veterans Administration has. A lot of our veterans have Parkinson's. But it does tend to be exercises focused on core strength, balance, and what we call metabolic exercises. So these may be swimming, these may be boxing, this basically cardio type activities. That can be very, very helpful. I like to have patients work with a physical therapist if there's a specific need for balance issue, if there's a component of knee, hip, or back limitation, orthopedic issues that can limit the exercise. That way they can get something that's customized, makes sense, and they get a program designed for them that they can then keep doing at home. I'm a big believer in the recumbent bicycle, bicycling, swimming, boxing's very popular, okay? Pedal for Parkinson's is another big and loud therapies. These are branded programs that are evidence-based. And so movement is helpful. I think there's a wide gamut of activities. I think ultimately finding something you enjoy doing that you'll stick with.
I was going to bring that up, is find something that you want to do. I'm a hiker, I'm a runner. I do that, maybe if you ask my wife, probably too much, but I enjoy it and it's something I love to do. My friend who is my age hates running, and so he's on a bike. My father enjoyed walking the dog, and then when he got older, it would be just in the house, going back and forth from his chair to the kitchen and back. I mean, it's doing what you can do, what you enjoy to do, and that you will stick with it, because as you mentioned, exercise is really important to helping slow or limit the progression. Sorry, I dropped it here. What role, really good question, what role does mental wellness play on a person's Parkinson's journey? A very, very key part. Mental wellness, I think about, we kind of divide mind and body, but, how you're feeling inside will dictate, how you're doing on the outside, very much so. And we see this very sensitive link between anxiety states and tremor, for instance. And, in patients that have anxiousness or depression, they won't do as well. They won't perform as well, both movement and mentally. And so, calling on the community resources, family and friends, exercise is helpful for the mental well-being. Oftentimes we do involve the help of counselors and psychiatrists, because without getting too much into the weeds, with the dopamine change is not only the chemical gasoline, but it's a feel-good chemical, along with serotonin, acetylcholine, and glutamate, all these other brain chemistries. And if we know 40 to 50% of patients with Parkinson changes develop anxiety or depression, that needs to be addressed, or you're fighting with one hand behind your back. So, so that involves oftentimes getting, a psychologist, a psychiatrist, getting the exercise involved, getting the faith groups involved, getting people connected with community organizations like pro-national organizations. And we, number one, need to be upfront and honest about it, because treating that can help other aspects of, again, quality of life. Yeah. You answered the first part of this question about exacerbating other symptoms or severity of other diseases. But is someone with Parkinson's more susceptible to metabolism disorders?
Yes, and I'm extrapolating that, and I'm not going to go too clinical. But the bottom line is, if we know Parkinson's slows down gastric emptying, can cause constipation. It slows down gut mobility and movement of things throughout the GI tract, then I would assume it impacts absorption. this is going to be different patient to patient, and with GLP-1 inhibitors, and if you've had bypass surgeries or short gut syndrome, we see all of these types of things in clinic. This influences also potentially drug choice, so if you're poor absorption or struggle with constipation, where do your Parkinson medicines absorb? In the gut. And if you're backed up with constipation, they're not going to absorb. You get dose failure and your symptoms erupt. And so, this is all intricately linked.
I think we've got time for one more question here, and then we'll have a few minutes just to have final thoughts. But does dopamine medication affect cognitive symptoms?
Yes, we both see this in our clinics. We oftentimes examine patients in on dopamine or off dopamine state, on medicine or off, and we see, I'll be honest, I see the dopamine make people brighter and more engaged, think clearer. We can see patients that when they take the dopamine, they may get sleepy or cloudy. And so this again argues to everybody's biology is different. But the gold standard is we know that generally patients feel better on dopamine. It is not a memory or cognition medicine. It treats the movement, stiffness, tremor, slowness symptoms. But many times we see patients feel and think better when their movements are better.
I would add that, I think the kind of a later symptom in many patients' Parkinson's is the Parkinson's-related dementia and cognition, and I think that's, it's kind of just a part of the progression of disease, but what we know from studies regarding neuromodulation in Parkinson's is that it tends to make the dementia worse. And so, I think a lot of patients are best suited for DBS kind of earlier on in their disease process for that reason, because, we want to get you off of some of those medications before the dementia and cognitive issues set in.
That's really helpful addition, because I know that that was part of the testing that I had to do for DBS. Any final parting thoughts that you would like to add or to share with the community that is here? Obviously, with lots of more questions, interest, and anything you would like to share at the end here.
I'll speak quickly. What an amazing event! I mean, the questions, the attendance, in the organization has been terrific. So again, want to give a thanks to Eileen and her team with the Parkinson Resource Organization, and Ethan, thank you for coming here from the Fox Foundation. Dr. Shields, and thank you all for attending. I think this is really important, bringing people together. We have, that number is truly, truly eye-opening, 10,000 patients. And, when we see that rate going up, we know there's gonna be more attention that needs to be paid. So bringing people together, talking about what we're doing now, talking about what's to come, inspiring hope because of the advances we have, and making sure we're connected in a community is a important goal, and it's a pleasure to be a part of.
Yeah, I ditto. I'm so thankful to be here. I'm so thankful for everybody to put this together and participate. I think probably, one of the big draws for me to come to the Coachella Valley was that there was nobody doing Parkinson's surgery, and I knew Dr. Legge, and I knew he was here, and I think it's crazy for people to drive 2 hours to get surgery. That makes me nervous as a surgeon, because if you have a problem and you have your surgeons 2 hours away, that's got to be scary as a patient. So our goal together is to, to take care of everybody locally. I know that it's hard right now because we just lost Dr. Hermanowitz, and I think we're working to build up our capacity for Dr. Legge, and I think that's a big push for our team. But I think it's important to know like we're here for you locally, and just keep on fighting the good fight.
I'll just add to, in closing, to help address the number of people that are going into movement disorder specialty, the Fox Foundation has a fellowship that we help recover all the costs of neurologists to go on into movement disorder. We cover their 2-year programming. It's called the Edmund J. Safra Foundation Fellowship, and we continually are adding to that, and we're hoping to put a focus in this area as well as other areas that are very, unfortunately, have very few representation. It's been a pleasure to be part of this panel. I can't thank both of you enough. I can thank Eileen and Pro. This is a journey that we are all on, whether or not you are a Parkie or not. This is something that we're doing together. It takes everybody here, it takes everybody outside, and it'll take people you haven't even met yet. And I think coming to things like this is a really wonderful part of your journey. So thank you all for your attention, your wonderful questions, and for your time. Thank you.